Very good morning to everyone. First of all, I want to thank Dr. Jaygatri Madam and Daikar sir for inviting me here. And most of the cases presented here are from the cases that have been referred from Arvind Hospital, mostly. And apart from this, more than a decade of experience with this cross-sectional imaging, most of the images will be shared here. Okay. So straight away we'll go into the imaging. So first we have to see which compartment are we dealing with, whether are we dealing with the ocular or intraconal or conal or extraconal, and the pathology are we dealing with the vascular, infectious, traumatic, acquired, metabolic, idiopathic, neoplastic, congenital, or as well as the drugs. So basically we should have a very good clinical history before proceeding the scans. And this presentation is mostly on a topic concerned with only CT scan. Okay. So first, we'll go into the ocular pathology. So this is a case of a retinoblastoma. So one of the most common tumors in a pediatric age group is the retinoblastoma, and like any amount of calcifications that is noted within the eyeball, and we have to suspect retinoblastoma. This was a case with the bilateral calcifications, and the calcifications are very well seen in the CT, but in MRI, the calcifications will not be seen, even though certain sequences are there that can only raise a possibility. But CT will be the first modality of choice, and I have also shown the MR images of parallel cases where the mass lesions are noted. And any calcification that is noted in the pineal gland, we have to think in terms of the trilateral, the retinoblastoma, because the pineal gland calcifications in the pediatric age group is very rare. And adults, the calcification, the senile scleral calcific plaques, the tendinous insertion of the optic nerve and the disc, all these things we can see in adults. So this is a case of retinoblastoma where the calcification is noted here, and the pineal gland calcification and the trilateral retinoblastoma has also to be ruled out. So scanning of the orbit should not be confined only with the orbit. Whenever retinoblastoma is suspected, the brain should also be screened. Any pineal gland calcification, we have to think in terms of the germinoma also. So one of the common tumors in adult in eyeball is going to be the melanoma. So this is a soft tissue density mass that is noted within the eyeball. And the number 2 for the DD is going to be the another mass lesions like hemangioma, leiomyoma, even the osteoma, even though they are less very common. So this was a case of orbital malignant melanoma where all the cones, the intraconal, the extraconal, the compartments are actually breached. It has moved from the extraconal into the globe also, the soft tissue density mass and almost of the similar density of the recti muscles or the extraocular muscles is noted here. It's very lobulated. In contrast, it's showing a homogeneous enhancement. This was a case of metastasis, and metastasis once again it breaches all the compartments. This is a case of breast metastasis, and the lesions are noted here within the intraconal area in the left and as well as in the right area, and with the homogeneous enhancement in the contrast study. This was another case of a lung carcinoma where the bone is actually eroded. You can very well see the sphenoid wing bone is eroded, and from into the extraaxial part of the brain, it is going into the extraconal or the conal area and displacing the right lateral rectus muscle and causing the optic nerve orbital apex narrowing is noted. So the patient presented with orbital symptoms, then we evaluated to found out to be the mass lesion, and further scanning only we found out that it was a case of a lung carcinoma with the metastasis. And the other mass lesions, one of the most common things we deal within the cone are going to be the optic nerve sheath meningioma, where the optic nerve is actually preserved here. This is called as a tram track sign here. And in contrast, it shows the homogeneous enhancement. So this was one case of optic nerve meningioma with a minimal mass lesion is noted. The optic nerve thickness is actually preserved, but this was another one mass lesion that is causing the optic extending into the orbital apex also with the narrowing. So one of the close DDs for optic nerve meningioma will be the optic nerve glioma, but the normal contour of the optic nerve is actually disrupted here. The tram track sign, what we saw in optic nerve meningioma, is not seen here. And this is a homogeneous enhancement is noted here. This is a similar image of an MRI that shows the optic nerve glioma, and definitely MR shows a better light here than with dealing with the anatomical components. Another one common thing what we see in daily practice is within the cone is the optic neuritis. So this is the right optic nerve that is normal thickness, but whereas in the left side, the optic nerve is actually thickened with the fat stranding with the heterogeneous enhancement is noted. So the baseline investigation in CT, we used to find this much, but whereas if you see the parallel imaging that is done in the MRI, where the optic nerve, then a nice heterogeneity is noted, the retrobulbar fat stranding is noted, that is extending up to the orbital apex. The right optic nerve is normal, but whereas the left optic nerve, this is the case of optic neuritis, which may be unilateral or as well as bilateral. So this is another case of dermoid cyst. So here, this was actually suspected to be a dacrocystocele initially, and later we found out that there was a mass lesion that is going into the extracorneal compartment, not in the medial canthus, but into the extracorneal compartment that is medial to the medial rectus muscle. And CT is one of the best modality of choices to detect dermoid cyst, because this black thing what we are seeing here is the fat. To detect fat, CT is a very good modality even than MRI, because in seconds we can scan this. And this is a case of a ruptured dermoid cyst. This black one is the fat with the solid and cystic components will be noted here. So another mass lesion that breaches all the compartment is the lymphoma. So lymphoma is actually one smooth, homogeneous, enhancing a mass lesion that is surrounding here along the curvature of the eyeball, and it is going into the cone also, and along the inferior rectus and as well as the lateral rectus muscle. We have to suspect lymphoma. So one more common tumor in pediatric age group is the rhabdomyosarcoma, and you might have very well known that it breaches all the compartments, even causes erosion of the bones, but here we are seeing only the optic nerve, and within the cone this mass lesion is noted that is engulfing the inferior rectus muscle also. This is another case of a rhabdomyosarcoma, one of the such a large, huge tumor that is going into the nasal cavity that is destroying the facial anatomy here, with the total dysmorphism of the face. And bone erosions are severely noted here. And this is axial CT scan. But what the color images, what we are seeing is the volume rendering images. In a one shot, it gives the clear images of how the facial dysmorphity is noted here. And this third one is again the volume rendering images, removing only the soft tissue and presenting only the bones here, with the bone erosions severely noted here. So one more thing within the ocular area is the persistent hyperplastic primary vitreous. So the normal hyaloid artery canal that does not integrate here, and the persistent of this thing between the optic nerve and as well as the lens, the presence like a mass lesion. We have to think in terms of persistent hyperplastic primary vitreous. They may be associated with a retinal detachment, and microphthalmia will also be noted here. So this will lead to glaucoma and as well as a cataract, and one of the common causes of leukocoria. Next, when pertaining to the globe, in the trauma cases, the globe rupture is one common thing where you see here. So the left eyeball, there is a microphthalmia, the size is reduced. You can see the anterior chamber is less. That is the one first gets attacked here. And the hyphema, hemorrhage, all those things will be associated. They may be presented with a fracture or without fractures. So CT is one of the good modalities here to compare between the right and the left side. The right one is the normal, but whereas in the left one the size is reduced, the vitreous also, the vitreous hemorrhage is noted here, but however the lens is a normal location in this case, which may also get dislodged. And within the globe, the retinal and as well as the choroidal detachments, ultrasound actually plays a very good role for these two things. But however, pertaining to the CT, the choroidal detachment, it crosses the optic nerve here at the attachment site, and also the 10 o'clock and 2 o'clock positions. Then also the choroidal detachment will traverse, which is not commonly seen in a retinal detachment. First one is a case of a choroidal detachment. The second one is actually the case of a retinal detachment, where the optic nerve insertion site is actually, it has not crossed here. This is another case of a choroidal detachment. So this is a sample case of ultrasound. So the clear anatomy of the globe is very well noted here between the first line of imaging modality. So this is a case of a chorioretinal detachment, and they may both be actually be associated also. Another lesion what we'll be seeing is the coloboma. So any defect here, the protrusion of the eyeball either anterior or as well as posterior, a small coloboma's defect, this is a congenital defect that is causing in the posterior aspect of the optic nerve insertion, and this is a large coloboma that is seen anteriorly in both eyeballs. Most of the colobomas will be associated with the CNS anomalies, and one of the most common CNS anomalies what we'll be undergoing is the corpus callosal agenesis associated with the pericallosal lipoma. So once a coloboma is actually suspected, it's better we go into the brain, and the screening of the brain is also mandatory. This is another case was suspected to be a coloboma, but it actually turned out to be a mass lesion that is arising from the anterior chamber here. This one is the mass lesion, but the presence initially it looks as if like a coloboma. And the left eye, there is a thysis bulbi with the calcification. And for calcification, CT is definitely the very good modality of choice, and the size of the eyeball is also very less here. So coloboma can also, they may be associated with the charge syndrome, coloboma, heart anomalies, schwannolatresia, retardation of the growth and the development, genital and ear anomalies. Coloboma can also be a part of the Koch syndrome with cerebellar vermis hypoplasia, oligophrenia, congenital ataxia, coloboma, and hepatic fibrosis. So coming to the corneal pathology. In corneal pathology, so one of the most common thing where we go in day-to-day practice is a TAO, that is a thyroid associated orbitopathy. So the right one is actually the patient is having the normal extraocular muscles, usually between 3 to 4 mm, but whereas in the left orbit, the extraocular muscles are actually very well thickened. And the one of the most common differential diagnosis for thyroid eye disease is a pseudotumor orbit. So the differentiating point between thyroid eye disease and pseudotumor orbit is pseudotumor orbit, they will be involving the tendinous portion also, but thyroid eye disease, mostly they will be sparing the tendinous portion. That is called as the Coca-Cola bottle sign, because only the tendons are actually, only that muscle belly is involved, but whereas the tendons are spared. This is called the Coca-Cola bottle sign. So this will be one of the hallmark signs in imaging to detect the thyroid eye disease. But pseudotumor orbit, the entire extraocular muscle is completely involved. Even the retrobulbar fat, there is will be fat standing with the inflammation, usually settle with the steroids. But thyroid eye disease, the basic cause has to be treated. Another extracornal, now we are going into the extracornal pathology. So in extracornal pathology, always when we are scanning with the orbit, we have to look over the sinuses also, because so this is a case of a sinusitis, right? Ethmoid sinusitis with the right lamina papriciae, erosions are noted. One of the most common erosion seen in the sinus is the right lamina papriciae, because it is a very thin and easily it will go into the orbit, and they will be causing periorbital abscess or cellulitis. We should not wait for the contrast enhancement to happen in the peripheral area to call it as abscess. Any sinusitis with erosion, internal soft tissue component that has gone into the extracornal or into the cornal compartment also, it can go here, and they will lead into periorbital abscess. This is a similar case with the MRI, and in MRI, this is T1 and T2 sequences, where you can see that the right ethmoid sinus, the sinusitis is noted, but can you see that the bone content is not clearly seen here? So to look into the osteology or the bone related issues, CT is definitely the first and the best modality of choice. But to see into the soft tissue structures where all it is invading, MRI will throw better light. So this is another case of aspergillus or fungus, so that will be causing the periorbital abscess. So mostly they may land with even with the venous thrombosis, like a superior and inferior ophthalmic vein venous thrombosis, or sometimes with the cavernous sinus thrombosis, and it may lead into CCF when it is very aggressive. So this is another case that is from Arvind only, it was referred. So this case is a case of right ethmoid sinus mucocele. So the right ethmoid sinus, there is a soft tissue density mass lesion. There is not, it's very homogeneous. It looks so benign, but however, the bone remodeling and it is noted. The right lamina papriciae erosion is noted. That is going into the extracornal compartment, and it is disturbing the muscle belly, and it is narrowing the cornal structures also. So this is a case of ethmoid sinus mucocele, and we should never confuse with malignancy in these cases. So another cause for this extracornal thing, the even it may cause the orbital apex narrowing and other syndromes. Mainly is the fibrous dysplasia. So here is a ground glassing that is noted along the sphenoid wing and as well as the lateral wall of the orbit. So this ground glassing, we have to suspect a monostotic or a polyostotic fibrous dysplasia. So other causes of this bone sclerosis or the bone ground glassing, we have to think in terms of a meningioma mass lesions that is causing sclerosis, sometimes Paget's disease, or if it is the entire skull is involved, the osteopetrosis has to be suspected. So this is another case of meningioma. So previously we saw the fibrous dysplasia. So here also this in the CT imaging, there is a sclerosis is noted. So this sclerosis is because of the meningioma that is present here in the extraaxial component that is noted in MRI in the first two images where the bone anatomy is not clearly made out, but somehow we can raise a possibility of the thickening of the bones. But the last fourth box is the CT image of the bone window. So this image shows that the hyperostosis is noted. That is the cause of this orbital apex narrowing, and even this patient presented with proptosis. It is a case of a meningioma N plaque. It is very thin. It is like a plaque-like structure that is noted along the sphenoid wing. This is called meningioma N plaque. So this is another case of a meningioma. This is a large meningioma that is noted here. It is almost in the density of the bone with the contrast showing very high homogeneous enhancement at the level of clivus. Yes, another extracorneal pathology that is in the infection area, the orbital 60 sarcosis, which is one common area. Here it is noted the rounded cystic structure with the peripheral enhancement. Internal scolex may or may not be seen, and it is confined within the lateral rectus and the extracorneal area with surrounding soft tissue swelling and inflammatory changes, which are also noted within the cone also. This is a case of orbital cystosarcosis. So any cyst-like thing with the internal scolex enhancement, depending on the four stages, either with enhancement or without enhancement, this solitary lesion that is located within the rectus, inside or outside, we have to think in terms of orbital cystosarcosis. This is another case of orbital cystosarcosis, and it is noted in the lateral rectus in the right side. The previous case was on the left side, but here it is in the confined within the right side, and internal enhancement is noted. This is the scolex, what we are seeing at this single dot. Another one tumor. So this was actually suspected to be a lymphoma, but turned out to be orbital inflammatory disease, sclerosing type. Almost homogeneous enhancement, breaching the compartments, conal, intraconal, extraconal, causing proptosis with a homogeneous enhancement. Almost similarly looking like lymphoma, but the HPE came out to be an orbital inflammatory disease, sclerosing. Next, so the scout what is taken in the CT scan before planning is called as the scout, or even in the X-ray lateral view also. So that always has to be closely monitored, because this case was a known case of osteopetrosis. So there is a uniform thickening of the entire skull vault. Even the vertebrae looks very dense here, which is not seen here, and the mandible is also the severe sclerosis is noted. So these patients will present with multiple cranial nerve palsies or a narrowing at the orbital apex. So before going into scan, a simple X-ray or a scout can throw better light as in this case. Then coming into the lacrimal gland diseases, so these are all the pathologies of what we'll be mostly dealing with, where the dacrocystitis or the adenitis and dacryops or the malignancy lesions of the pleum of the adenoma or the adenoid cystic carcinomas will be commonly seen here. So some of the lacrimal gland lesion, this was a case suspected to be dacroadenitis, but later we found out that internal there is a cystic lesion is noted within the lacrimal gland, that is in the anterosuprolateral aspect of the eyeball, where peripheral enhancement is noted in the contrast study. The right one is actually the contrast images that is noted in the vessels also. Only in the peripheral we are seeing the enhancement, but internal there is no enhancement. Rest of the eyeballs, the recti muscles and the extraocular muscles all looks normal. This we gave the diagnosis of dacryops. So in 3D imaging of the CT, we can give the multiplanar imaging of a coronal and as well as the sagittal images. Apart from the axial images, will show better light here. So one of the most common things in lacrimal gland is actually the dacroadenitis, that is infection and inflammation of the lacrimal gland here. This case was actually previously they presented with the orbital cellulitis, that is in the preseptal compartment. So orbital cellulitis, we have to classify whether it is a preseptal or a postseptal or septal area. And the cellulitis actually got subsided, but the lacrimal gland adenitis actually remained, and the patient came for nearly 2 weeks after the presence of cellulitis, they had this lacrimal adenitis. So this is the same case of dacroadenitis that is noted in the supralateral aspect of the eyeball. One more case. So this was done some 6 or 7 years back, I think, from AEH only. So another soft tissue tumor that is noted in the lacrimal glandia with a severe bone erosions in the anterocranial fossa that is breaching the compartments. It's going outside the periorbital area also with the soft tissue swelling with the heterogeneous enhancement in the contrast, and the severe bone erosions are noted in the bone window. So this was a case of adenocarcinoma of the lacrimal gland. Next, this was a case suspected to be dacrocystocele, but however, the differentials were a simple conjunctival cyst and dacrocystocele that is noted in the medial aspect that is going well into the extracornal area, medial to the medial rectus muscle with a homogeneous cystic structure, and it's in the case of a pediatric case. This was another case of in the medial canthus, a mass lesion that is noted. CT scan, once again, is one of the finest modalities to detect the dermoid. So in a CT scan, when we see this hypodense area, that is fat attenuation, we can mention the Hounsfield units basing on whether it is a solid, whether it is a cyst or a fat. So fat containing lesion within the medial canthus turned out to be an angular dermoid. So this is a 3D volume rendering image. We can create images like a module here, and this is the same case noted in the medial canthus. So this is the dermoid that is protruding here. Another, the vascular lesions. When pertaining to the vascular lesions, when there are multiple this iso-intense soft tissue lesions that are noted in the periorbital area with a heterogeneous enhancement, and mostly they will be noted in the pediatric tube, the involute in 5 to 7 years. We have to think in terms of the capillary hemangioma. They may be present with calcification or they may not be present with calcification. When capillary hemangioma is noted, we have to think in terms of the face syndrome, the posterior fossa malformations, hemangiomas, arterial anomalies, cardiac malformations, eye abnormalities such as coloboma and as well as glaucoma. So this is another case of orbital hemangioma. Once again, there is no boundaries for this. This is noted within the intraconal compartment, the soft tissue mass with internal calcifications that is disrupting the optic nerve, displacing it immediately. And in arterial phase enhancement of the contrast, only subtle enhancement is noted. That is the differentiating point here. Other tumors like malignancy or any other thing that will have a homogeneous enhancement intensely. But this C is actually the arterial phase study where only subtle enhancement is noted here. D is the venous phase where homogeneous, intense, extensive enhancement is noted. So this can give a clue of hemangioma and calcification. Always we have to think in terms of orbital hemangioma. So other similar DDs for this is the venous vascular malformation. There's a phlebolith-like thing. Either it may be unilocular or either it may be multilobulated, and most common age is in the 45 years of women. We have to think in terms of venous vascular malformations. So similar lesions like a hemangioma and vascular malformations, but this time they don't enhance in contrast study because lymphatics, they don't enhance, but the multilobulated lesions breaching the conal, breaching the boundaries, they may go into the periorbital, into the conal or in the extraconal area with the multilobulated with the fluid levels. Then we have to think in terms of the lymphatic malformations. It is a group, it's from the cystic hygroma groups, and most commonly they are in the childhood. They may be mostly they are multi-compartmental. Sometimes they may be also be unicompartmental, is very rare when compared to lymphatic malformations. They may be associated with the Turner syndrome or the fetus alcohol syndrome. Absence from enhancement in the contrast is one of the clinching points to diagnose this lymphatic malformations. And sometimes in trauma or something, they touch on bleed these lesions also. Sometimes they may also enhance suspected when they have an internal venous compartment. They may also have some minimal enhancement. Okay, this was another case of Tolosa Hunt syndrome. So the painful ophthalmoplegia, this is a case of MR study, and similar images we can also get in CT study also. So surrounding the carotid artery. So this is the clinoid portion of the internal carotid artery. There is subtle increase in the enhancement that is narrowing the diameter of the internal carotid artery in the supraclinoid portion. So this will be causing multiple cranial nerve pathologies with the painful ophthalmoplegia. This was a case of a Tolosa Hunt syndrome. So the left internal carotid artery, the diameter is normal, but whereas in the right thing, it is narrowed. Only half the diameter is only narrowed, but see the intense enhancement. enhancement. So this has to be picked up in a contrast study to raise the possibility of Tolosa-Hunt syndrome. Okay, another thing is the orbital varix. So most of the orbital varix, they can be picked up in a normal CT itself, but however, contrast definitely will show the internal enhancement. But sometimes they may be requirement of a Valsalva procedure, because this was a case of the CT that is taken without Valsalva in the top and in the bottom during the Valsalva. Because of the pressure, there is intense enhancement is noted. This was a case of orbital varix. Okay, this is a similar case of a orbital varix. This is from Arvind AEH only, and in the external area, this intense enhancement is noted here. One common thing where suspected is the caroticocavernous fistula, preceded with the trauma with the pulsatile exophthalmos. The CCF has to be ruled out. So pertaining to CCF, either we have to do an MR angiogram or a CT orbit or CT brain orbit with the CT angiogram or a DSA. So any communication between the carotid artery, internal carotid artery, and the cavernous sinus, or between the superior ophthalmic vein and the carotid artery, and there are multiple types are there. So this was a case of superior ophthalmic vein, and directly it is, I think, communicating with the internal carotid artery. So this will be causing this painful exophthalmos with the bulging, actually preceded with the trauma history. When suspecting foreign bodies, definitely CT is actually the first in the apart from ultrasound. CT is a very good modality of choice when we are thinking about the metallic foreign bodies, because the wood fragments, the organic foreign bodies, unusual air packets, MRI will throw better light. Wood pieces, if it is somewhat large, or as well as with the internal hyperdense content, then definitely CT can throw better light, because we'll be seeing in the next slides. But the small pieces of wood CT detecting the wood fragments will be very meager. So this was a case of an intraconal metallic foreign body that is noted just medial to the medial rectus muscle here. So these are normal scleral calcification. So we have to differentiate which is calcification, which is foreign body. By basing on the Hounsfield units, we can measure this is metallic density and this is just a calcification. We have to differentiate. When thinking of metallic foreign body, please do not refer the case for MRI, because metallic foreign bodies will dislodge in the power of like 1.5 Tesla MRI. The metallic foreign bodies will dislodge, they will go even into the brain and becomes very difficult to remove them. So always the thinking on the foreign bodies, if it is wood or something else, we can do MRI. If it is suspected of metal, better to confine with ultrasound or as well as with the CT. So this is in trauma with a blowout fracture. So the inferior and the medial wall of the orbits are one of the commonest wall that has to be get fractured because of the thinnest section, thinnest bones what we see in the orbit. So the inferior orbit, there's a blowout fracture with the protrusion of the extraorbital fat and as well as the inferior rectus muscle also. So the width and the depth of the fracture will be mentioned here. So this is a case of the wooden piece foreign body. Luckily, we got it in CT itself. So here it is going above the eyeball along the superior rectus muscle. Such a large wood piece was noted here. The same wood piece foreign body that was in coronal and as well as in axial planes along the superior rectus muscle. So this was a case from dynamite blast from the sand mines, from the mines here. So there was a multiple metallic pieces that is noted inside the globe in the left side with the pneumo-orbit and right side in the periorbital area and multiple soft tissue. These hyperdense dot lesions, what we are seeing is the metallic foreign bodies. Mainly they come from the bomb blast from the mines, and CT is definitely the one and the best modality of this. Cases like this thing, if MRI is done, definitely these pieces will dislodge. We don't know to which direction that the metallic pieces will go on. So we have to be very careful when choosing the cases between CT and as well as MR. So this is a similar case of the previous case of the bomb blast case with the mines and multiple metallic foreign bodies are noted here. When scanning these metallic foreign bodies, we get these artifacts. These star-like artifacts are noted here. But however, this is the minimal amount of artifact what we are seeing here, because in latest CT machines we have this metal artifact reduction softwares that will reduce nicely and increasing the thickness, and as well as the number of slices, the artifacts can be reduced. Because in previous years, only when single or dual slice machines were there, when there was no metal artifact reduction, definitely even a small amount of a metal foreign body will have a streak artifact of the entire eyeball. So therefore, the external anatomy and other pathology associated we cannot pick up. So these are all done with the latest 32 slice CT machines with metal artifact reduction softwares, and this is the meager amount of artifact what we got here. This is a metallic foreign body. So Hounsfield for these metal foreign bodies will be around in thousands or 2000s. Suppose if you have a doubt whether it is a calcification, it will be only in 50s or hundreds. Thank you.